Good evening, and on behalf of the Central Shenandoah Health District, Augusta Health, and all the other public service agencies, welcome to our Ebola Public Forum. My name is Lisa Schwenk, and I'm the Director of Public Relations and Community Outreach here at Augusta Health. So this evening, we're going to have 3 different presentations from 3 different panel of experts here. The first will be from Dr. Allison Baroco. She's Augusta Health's Medical Director of Infectious Disease, and she will speak on Ebola in general. Then Jonathan Falk, the District Epidemiologist for the Central Shenandoah Health District, will speak about public health response to Ebola. And Dr. Scott Just, who is the Associate Chief Medical Officer at Augusta Health and the head of our Ebola preparedness team, will update you on what Augusta Health has done to prepare for a suspected case of Ebola. So our first speaker is Dr. Baroco on Ebola.
I'm happy we're having this forum. I know there's been a lot of fear in the community, and hopefully today I can help allay some of those fears. This is a very general presentation, and our hope is that after the 3 presentations we can answer your questions. When we speak about Ebola, I only have the questions up here. I don't have a formal presentation or formal slides for you, and I do recommend the CDC website. It has very specific information in regards to everything we'll talk about tonight. So at Augusta Health, we understand that there are a lot of fears in the community. The media has definitely been speaking about Ebola on a daily basis, and the more you hear about it, the more we have fears about it. The best way to allay those fears is to talk about the facts. Fact number 1, how does Ebola spread? It spreads through bodily secretions, blood, sweat, feces, urine, sputum, semen. It is not airborne. And it cannot be spread before fever. And in fact, some experts say that Ebola is not spread until your 3rd day of fever. So it is unlikely to be in the community and around the general public and be exposed to Ebola unless somebody is a return traveler from Western Africa or somebody has been diagnosed with Ebola virus disease. Can Ebola live on hard surfaces? It's not very hardy in our environment. In fact, it dries out fairly quickly and it dies. What they learned from the first patients treated at Emory, they went to those hospital rooms and they looked at those surfaces and they saw that even looking at the high-touch surfaces like bed rails, that they could not detect any virus on those surfaces. So it's highly unlikely that this virus would persist in the environment if a person with the disease were roaming through the community. What are the symptoms for Ebola virus disease? The onset is typically 5 to 10 days from exposure to the virus, though the range of days is 2 to 21 days. The typical symptoms are fever, and over 90% of people have fever, and gastrointestinal symptoms, including profuse nausea, vomiting, diarrhea. In the initial strains of Ebola, it was initially termed Ebola hemorrhagic fever because there were a lot of patients presenting with bleeding symptoms. With this particular strain that is circulating through Western Africa, less than 50% of the patients are having bleeding or hemorrhagic symptoms. And so they've renamed it or redefined it as the Ebola virus disease rather than Ebola hemorrhagic fever. When do you know you're safe after a possible exposure? 21 days. There has not been any cases defined after 21 days of exposure. So the Public Health Department and Mr. Falk will speak later in regards to their efforts, usually are evaluating and monitoring people to 21 days. And going back, I'm sorry, when we talk about symptoms, I did want to mention historically it was pretty fascinating with this particular outbreak in Western Africa. When it began to evolve, this strain, we mentioned that they've redefined Ebola hemorrhagic fever to actually be more of a disease of vomiting and diarrhea. Initially, when it arrived in that area, they thought they had a cholera outbreak due to the profuse amount of diarrhea the patients were having. And it took some time to actually figure out it was an Ebola virus disease. And unfortunately, because of that factor, as well as the healthcare infrastructure in Western Africa, it became as large as it is today in Western Africa. So we talked about when you know you're safe after a possible exposure, 21 days. Why do some people die from Ebola while others survive it? This is pretty important. We have to remember that in Africa, there's very poor health care. And in fact, in Liberia, they have the second lowest physician to people ratio in the world. There are only approximately 50 physicians in the entire country. And so unfortunately, there are not many healthcare workers in the area of this outbreak, and there was a late response through World Health Organizations. And in this area, if somebody has diarrhea and they need IV fluids, many patients are not able to get the basic healthcare measures such as IV fluids and all of the basic things that we support people in the hospital with to help their survival. Since the cases in the United States that have come back and have been treated, we've noticed that those healthcare workers have a decreased mortality rate in the population treated here in the United States. So although the reported mortality is quite high, it may not be as high as speculated because there is a major difference in health care where the outbreak is compared to here. So what is my risk of catching Ebola here in the United States? They've done some mathematical modeling of this, and currently your chance of contracting Ebola in America this year, based on the model of the imported cases, is 1 in 13.3 million. If you look at this chart, what you can see is what we should be concerned is basic health measures such as wearing a seatbelt, following rules. Being in a car accident, your risk of being killed is 1 in 9,100. And you can read the other facts on the chart. Now, your chance of contracting Ebola in Monrovia this week, unfortunately, is 1 in 5,000. And so public health measures are occurring internationally to help with this. And then in the United States, Jonathan Falk will go through some of the measures we're taking to prevent what has happened over there from coming to the U.S. That's the end of my presentation. Like we mentioned before, we'll have the other two speakers come up and talk about the Ebola preparedness plan and our public health measures, and we're very happy to answer all of your questions tonight. Thank you.
Thank you, Dr. Baroco. So for this evening, I'm going to touch on some Ebola basics as well as an update regarding the current situation, and then talk a little bit more about our response from public health as well as our coordination with a number of organizations within your local community. I'll do my best not to spend too much time on some of the points that Dr. Baroco has already brought up. To begin, Ebola was first discovered in 1976. Since that time, there have been 5 different strains that have been identified, 4 of which cause disease in humans. Since 1976, there have been, including the one that we're obviously focused on today, 26 outbreaks sporadically that have showed up in Africa. And based on our investigations, and I say our, in terms of the World Health Organization and CDC, we believe we're reasonably sure that bats are the reservoir, the animal that sort of has this virus. What typically happens, there's some other animal population or direct contact with bats that allows for that virus to cross over from that population into a local population within Africa. And from there, we end up getting outbreaks of various sizes. Before this current outbreak, we've had outbreaks of Ebola of 1 case all the way up to 300-400 cases. This is a picture of the virus as it is budding out of an infected cell. I just wanted to kind of show you that because I think it's a very neat image, and that's something the CDC has available on their public health images library. Again, this is a virus that is found in blood and body fluids. People are contagious after symptom onset, and the fatality rates from those outbreaks that I mentioned have ranged from 25% to 90%, depending on things like which strain was causing the outbreak, what was the healthcare infrastructure within the affected country and population. These are the symptoms that Dr. Baroco brought up. So there you have them again. Fever, headache, diarrhea, vomiting, stomach pain, unexplained bleeding, and muscle pains. And these would be some of the things that we would be looking at during our public health investigation. And the incubation period, so when someone is exposed to the time that they start developing symptoms, can range from 2 to 21 days, and that plays a role in our investigations, and certainly our screening of travelers from those 3 affected countries. This particular outbreak began in December of 2013 in a 2-year-old child. We believe that this child had contact with some sort of animal in his or her environment. From there, family members as well as some of the local healthcare workers were then exposed, and the outbreak just kind of continued from there. One of the challenges with this outbreak is that between those 3 West African countries, Guinea, Sierra Leone, and Liberia, this particular epidemic happened sort of at the epicenter where those 3 countries meet. And so some of the communication challenges between those countries and coordination of a response were also a factor in as to why this was able to kind of spin out of control so quickly very early on. You'll notice the date there is October 24th. This is a very fluid situation. The affected countries and the numbers of cases change on a daily basis, and whenever these numbers are reported, we always have to kind of put a timestamp to them. Because I couldn't tell you right now the numbers of cases and deaths as of the 29th. Based on the official reporting, we have to go back a few days. You notice that the CDC has them broken down into 3 different groups. We have countries with widespread transmission, and those are the 3 that I mentioned before, Guinea, Liberia, Sierra Leone. We then have countries that have been affected by travel-associated cases. These are cases that have traveled to those countries and then have also subsequently caused localized transmission to other people within those countries. Nigeria, Spain, and the United States are 3 that are listed here. Nigeria, just recently, within the last week and a half, was declared Ebola-free. So they had a traveler from Liberia, I believe, come to Nigeria. That individual exposed a number of healthcare workers. There were a number of healthcare workers that developed Ebola, and then they were able to lock that down. And after 42 days, or 2 times that incubation period of 21 days, the WHO, the World Health Organization, declared that country to be Ebola-free from this outbreak. And then there are countries that have had just, cases of travelers coming in and developing disease, but no localized transmission. And that's Mali and Senegal. The numbers, again, as of October 24th, are approximately 10,000 and some change, and then that's including all the countries that were listed there. And the deaths were around 5,600 with some change. I like this graph. If you look at the bottom, there's a timeline from 1976 all the way to present, and you can see some of those sporadic outbreaks and just how much different this particular situation is in West Africa compared to all the other outbreaks. This is very much unprecedented, and this is the first outbreak of Ebola in West Africa. And you can see there the dark color are the number of deaths, and then the lighter color is the total number of cases. Overall, the mortality rate is approximately 50%. But like Dr. Baroco said, that could there were some factors that played a role as to why it seems to be so high, especially in that area. And this is just showing the trend over time of those cases as they have been documented and developing as this outbreak has been ongoing. We are clearly not quite towards the peak. There is some data that suggests that Liberia may be close to that, but the WHO, the World Health Organization, is still investigating to confirm that. However, for all 3 of those countries, we're still seeing an upward trend of cases. Bringing this a little bit more closer to home, while this is a very low risk, Dr. Baroco had a very nice graph of showing the risk for us in the U.S. And obviously, during Shark Week. I'm very concerned about shark attacks, my risk, even though it's very low. We as a community have been working since August to really partner between a number of different agencies. When we take a look at the Dallas situation and how that played out, there were a number of groups that had to come together, including the CDC, the State Health Department, local health department, fire and rescue, EMS, law enforcement, hazardous materials, emergency management. The hospital was obviously a critical partner in all of that, local schools, social services for those folks that had to be quarantined, colleges, I mean, the list goes on and on and on. And from a public health perspective, the Virginia Department of Health and your local health department are really kind of the lead agency for an event like this, and we are responsible for reaching out to all these groups. And we've been doing that over the last few weeks. I think 2 weeks ago we had 2 different meetings, one in Harrisonburg and one down here, where we were meeting with all these folks, including Dr. Baroco and Dr. Just, to discuss what would we do if we had a case, looking at how we would manage that, how we would identify contacts, and then how we would do our investigation from there. And that kind of brings up this first part of our local health department actions, VDH actions, that case management. So on the off chance that we do have a traveler that comes into our local community here from West Africa and they do develop symptoms, how do we gather that information on that patient? How do we coordinate testing through the state lab? And then gather more information on the contacts of that individual, and then how does the health department reach out to those contacts, monitor them for the full 21 days? What other needs do we have to kind of address, either working with the hospital, infection control, or DEQ, waste management, or social services, and if we have people that need to be quarantined and providing services for them. More recently, the governor had a press release talking about how we would be monitoring travelers from those 3 countries. And Customs Border Patrol and the CDC is stationed in Dulles. And as travelers arrive, they will be screened and placed into a different risk category, high, some, low, or no risk. And based on those, there are different steps or stages ranging from quarantine to restricted travel to monitoring. And it's a very complicated and very detailed process, and we've been really working that out between the state level VDH folks and ourselves here locally. To make sure that once we do have someone that we need to monitor, we can follow them for the 21 days. And then lastly is working with partners like Augusta Health to provide education to the public, whether that's press releases or having the health commissioner put out letters to physicians, or kind of pull together online resources or social media resources and information to kind of push out. And really, it's along with trust, that should be care at the top there. So instead of being pulled away and kind of diverging to the path of fear, our goal really is to build trust with our communities and with our partners, so that way when something like this happens, we can all act together as a group, as a team, and have that trust to kind of move through and address the safety for all those involved, community and health. And that's just my contact information, since I didn't have that at the meeting. So.
How's everybody doing? Good. Thanks for coming tonight. I want to take a minute to thank Lisa for putting this together. So thank you, Lisa, for getting us in the room together so we can talk about it tonight. Thanks a lot. So what's Augusta Health doing to prepare for Ebola? Well, the first thing that we have to do is to make sure whatever we're doing to take care of our patients is safe. We need to have safety for our patients, for our staff, for our visitors, and for our community. So our plan has been formulated from the beginning with the bedrock being safety. We need to take safety precautions at every turn. So our plan meets or exceeds the guidance of the CDC and the Virginia Department of Health. As most of you know, we pretty regularly treat serious infections at the hospital. We are also accustomed to taking care of many patients with life-threatening illness. So this is what we do. We know how to take care of sick patients. We just need to prepare ourselves for this particular type of patient because we've never had an Ebola patient before. Augusta Health has an existing emergency operations plan. The Ebola preparedness plan is simply an iteration of what already exists as our emergency operations plan. So what are our priorities when we are thinking about Ebola? First, safety, as I mentioned. Early detection and identification of potential patients. Early protection for the patient, for the staff, for the community, and for our visitors. Early containment and early notification of the CDC and the local health department. So safety first. So several weeks ago, around the beginning of October, we convened an Ebola preparedness team, and I was pleasantly surprised to be asked to be the leader of that team. So I have put together a multidisciplinary team to think about our strategy and our planning and our vision for how we would manage the Ebola patient at Augusta Health. We've developed a comprehensive internal response plan, and we've developed clinical treatment plans. We've also worked with external agencies, as Jonathan mentioned, to develop a community program. We have developed step-by-step checklists to help guide us through the process. When you're working with something that you don't do every day, much like pilots do, we want to use a checklist to make sure that we don't miss any steps along the way. We've conducted tabletop exercises to work through the plan in detail, and we modify the plan as necessary. In regards to our community, the external plan was developed in conjunction with local municipalities. We met with the dispatchers for the 911 centers, firemen, police officers, and EMS providers, as well as our local health department and our local schools. But it really comes down to practice, practice, practice. And I like the saying, you don't practice until you get it right. You practice until you can't get it wrong. And that's how good we need to be at this. We've put together a core group of care team members, and with a core group, it's a smaller group, so it's easier to give them specialty training. We've trained everyone in the hospital in basic personal protective equipment, or PPE as we call it. But we've also trained this core team in more specialized PPE. This photo was taken yesterday of one of our emergency room nurses during a live operational exercise or drill. This is what the full PPE suit looks like. This suit is protected in every way. This is one of the concerns that we learned from Dallas, was that the nurses didn't feel prepared. The staff didn't feel prepared. There were portions of the skin that we believe may have been left uncovered. So we wanted to cover all of our bases and cover all of our skin. So this suit is a Tyvek suit, and it includes feet, arms, legs, neck, and a hood. Over top of the hood goes a breathing apparatus called a PAPR, P-A-P-R, and that has positive flow of fresh air, which is filtered and is safe for breathing. It's also cool so that the suit doesn't get too hot, because without that PAPR device, as we found out yesterday, some of our nurses could potentially overheat if they stayed in that suit. So this was a good exercise for us to practice our system yesterday. This is the side view of that suit. So there's no uncovered skin here, there's no exposed skin, very low risk of potential contamination. We also use a buddy system. This is something that the Doctors Without Borders group has been using for years, since 1976. And I think they just had their first worker or doctor infected with Dr. Spencer in New York, and they worked with Doctors Without Borders. So for many years they've been doing this successfully. So the greatest risk is when you're removing the PPE, because that's when the PPE is potentially contaminated. And so during this time, the process must be meticulous, precise, and disciplined. And we use a buddy or an observer to remove the equipment so that you're safe while you're doing it. Prior to removing the equipment, we spray our nurses down or the staff down, whoever's wearing the equipment, with bleach from the neck down to kill any of the virus that may potentially be on them. And then the buddy removes the teammate's PPE. And again, we use our pilot-style checklist to make sure we don't miss any steps along the way. We also have trained all of our staff to ask the screening questions for Ebola. We have many portals of potential entry at Augusta Health, including our primary care physician offices, urgent cares, convenient cares, free clinic, OB, many places where patients could come in to our system. So we've trained all of those employees to ask the two screening questions. Do you have flu-like symptoms, fever, nausea, vomiting, muscle aches, and have you had a travel history that's concerning to the questionnaire? And if you answer yes to both of those questions, then we have procedures in place at all of those entry points to protect the patient, protect the staff, protect the visitors, and protect the community, and get the patient to the emergency department where we can care for them safe. This is our screening tool, again, using the checklist so we don't miss any steps along the way. This is deployed at the front desk of every office in the Augusta Health System, as well as our emergency department, and with nurses that call for pre-op questionnaires or other elective procedures for asking these questions to be sure that we are informed as soon as possible that we have a potential patient. We have ensured that we have both the correct types of supplies and the correct inventory of supplies. One of the problems that the Emory folks ran into in Atlanta was how to deal with wastewater. And we've been working closely with our waste treatment municipalities, and the strategy that was used successfully in Atlanta and one that is in our plan includes disinfecting any waste with a bleach solution. Now, the bleach solution is above and beyond what the CDC recommends. We know that this virus is not transmitted in water. We know this virus is not transmitted in food. We know this virus is not transmitted in the air. So there is no risk of this being transmitted in the wastewater system, but to take an extra precaution, we are disinfecting with bleach to be certain. So we have a plan in our emergency department to deploy an isolation unit. And this will, again, provide safety for our patients, our staff, our visitors, and our community. It also will allow us to continue normal operation for the majority of our emergency department. We have 34 rooms in our emergency department. This will require 2 of those rooms, which are negative pressure rooms for safety. The other 32 rooms will operate as well. It takes about 30 minutes to set up this isolation unit. And in the meantime, patients are contained and isolated in our decontamination room, which is attached to the emergency department. This was during our drill yesterday. This is a pretend drill patient who is exiting our decontamination room and heading into our isolation suite. This is a schematic of what the emergency department looks like. If you're familiar at all with the facilities, this is the end where the ambulance patients enter. This is the pull-through for the paramedics. We have 2 secure holding rooms in the back that are negative pressure rooms, and our decontamination room, which communicates with the outside, is adjacent. So what we will do is seal off this hallway here, here, and here to essentially contain and isolate this whole hallway to protect, again, for safety for our patients and the remainder of the staff. The rest of the emergency department will function as normal. So we have exercised our plan by performing operational drills. We need more practice. We will continue to practice. We will continue to learn. We will continue to improve. We learn every day from the experiences of others, the experiences in Atlanta, the experiences in Dallas, the experiences in New York. Yesterday during our live drill, we invited in the health department to observe and provide feedback to make sure that we were doing things safely and wisely. And as I mentioned on that bottom line there, this process must be nimble and it must be dynamic.